We have with us today, who happens to be a lady by the name of Dr. Leigh Minuk. Dr. Leigh is a respirologist and clinical instructor at Vancouver General Hospital. She is a recent graduate of the University of Toronto Respirology and Interstitial Lung Disease Training Programs and completed a clinical epidemiology diploma at McMaster University. She has a special interest in cystic lung disease and sarcoidosis. She is involved with the administration of clinical trials and is focused on quality improvement and resident education. Please help me welcome Dr. Leigh Minuk.
Thank you for that warm welcome. It truly is a pleasure to be here. I heard about the patient forum last year shortly after coming to Vancouver. I moved here in October, so I just missed it. So I was very excited to get invited to speak here this year. I think this is an excellent opportunity and amazing that we can all meet back in person now and that we've kind of got the pandemic has ended and that now we're kind of back getting to see each other in person. So that's really, really exciting, and thank you for having me. I'm going to be talking about vaccines today, actually on the topic of pandemic, and helping you make sense of vaccine recommendations. You can't see it here, but that's actually supposed to be a vaccine heading into a vial. It doesn't really look like it, but this is my requisite disclosures slide. I have speaking honoraria and I work on an advisory board for Boehringer Ingelheim. I also speak for AstraZeneca. I have no involvement in vaccine supply and procurement. Most of those folks are actually infectious diseases doctors, not respirologists, and they're usually involved with the drug companies themselves. So what we're going to talk about today, a little bit about the general principles behind vaccines, and I'm not going to be getting into very, very specific things about the individual vaccines and exactly how they work, but we'll sort of hint at it for some of the vaccines. I'm going to go over the vaccines that are currently covered in this province and which ones aren't covered, which ones you'd have to pay out of pocket for. And that doesn't mean that some of them aren't recommended by our Canadian governing body for vaccines. It just sort of depends on what the province happens to get or supply. So it means that a lot of those vaccines that aren't recommended or that aren't provided by the province, you can often still get or pay for out of pocket. So the vaccines I'm going to be going over are the COVID-19 vaccine, the flu vaccine, which is going to be coming out very soon, the pneumonia vaccines, as well as the RSV vaccines, which we've had a lot of questions about in the recent year or two. I'm not going to be talking specifically about pertussis vaccines, but it is recommended that you have a booster once in adulthood if you are not immunosuppressed. If you are immunosuppressed, you may actually need one plus another booster. I would speak with your doctor specifically about that. If you've had a transplant, definitely speak to your transplant team about that. And the shingles vaccine, which is also recommended for those over the age of 50. So first I want to talk a little bit about viruses, how they get transmitted. And this is something I think we've all become very familiar with, probably more familiar than we've wanted to be over the past 4 years. But essentially you have somebody who gets infected, and then they infect others. You can see these sort of red folks are supposed to be the infected people. Unfortunately, life doesn't work that way, and you don't know who's walking around with an infection and who is not. And then once you're sick, you start coughing, and you cough, and sometimes that can travel really, really far. What we've learned through COVID is that there was a lot of debate as to whether COVID was airborne or not. It's not truly airborne, it just travels really far and stays in the air for a really long time. So it's effectively like being airborne. And then those droplets hang out in the air, you breathe them in, or they fall on surfaces or objects. And so again, breathing them in, you may touch something that has some of those droplets on them, and then the droplets eventually get into your nose and mouth because what we do is we rub our eyes, we rub our face, we eat, we go about our day and don't really pick up on it because we don't see them. So this may seem really obvious because I'll be talking about vaccines, They are the most important protection against severe illness. But there are things you can do to prevent getting sick in the first place. So, of course, avoid others who are sick. But as I mentioned, unfortunately, we don't know who's sick sometimes and who isn't. And as many of you know, sometimes you're coughing, but that doesn't necessarily mean that you're sick. And that's the problem with cough. You know, in lung disease, people think you're sick, but you're not actually contagious. So we don't often know. Wash your hands frequently, so definitely before eating, when getting home. Avoid touching your face near your mouth, nose, or eyes if you can, and ensure your workplace or home stocks tissues, hand sanitizer if you're going to be traveling or going about your business or your day. So the general principles behind vaccines that I want to go over, and many of you might have heard about this or have some sense of this, but basically the way that viral vaccines are engineered is that viruses have these antigens around their viral envelope. And those antigens are kind of like the calling card for what the organism is. It helps identify the organism. And so those antigens, when they enter the body's smart. So the white blood cells flock to them because they're abnormal, and the white blood cells want to fight whatever this abnormal foreign invader is. And what they do is they recognize this antigen or they don't recognize it. If they don't recognize it, your white blood cells start producing these proteins called antibodies that try to match up with those antigens to target so that it can send in more troops, more recruits to try to fight those infections. So all these antibodies get produced, you get an antibody response, that causes fever, it makes you feel really unwell, and then eventually you get better. Vaccines work very similarly in the sense that instead of taking the entire virus, in some vaccines they do actually take the entire virus, but most of the vaccines we obtain in adulthood actually contain just a protein piece of that antigen so that it essentially sends it into your body, makes you think that you've been exposed to that virus without actually getting sick or having any of the bad stuff. And then your white blood cells produce all these antibodies, and then they store them for later. They just store a few for later in case you see it again, and then they're able to send those antibodies out to neutralize it. So you have this new pathogen here. You've taken a little piece of antigen, so we identify that antigen, and then what we do is we put it in the body in some way. Your body makes a new antibody, and you're now sort of primed to fight that infection if you see it. Now, sometimes we don't put proteins in the body, and this is what was really fancy, and I think what worried some folks about COVID is that the COVID vaccine was entirely new technology. No one had done this before, but they essentially took just the RNA, which is kind of like a single strand of DNA, like transcript, so it's a code, and they put that into a vaccine so that when they injected it into the body, it wasn't just like a piece of protein from the virus itself. It was the code that told your body, told your white blood cells, how to actually engineer or make these proteins. So then your body made these spike proteins that we would typically inject in like a normal vaccine, but in this vaccine, it actually used your body's own machinery to create these spike proteins, and then your immune cells looked at those spike proteins, which didn't have any infectious material at all, and they were able to say, okay, if we see these spike proteins again, we're going to know what to do. We're going to know how to attack them. So this was a really new and exciting way to make vaccines, and now I think we'll see more and more of that, hopefully in the future. I just want to make a little distinction here between immunocompromising conditions and chronic lung disease, because I'll be referring to immunocompromised versus chronic lung disease in several points of this talk. So chronic lung disease, COPD, ILD, asthma, bronchiectasis, doesn't mean that you're necessarily immunocompromised. You may be both immunocompromised and have a chronic lung disease, but specific immunocompromising conditions are usually things that either you've acquired, so HIV would be an immunocompromising condition, or they're things that we've done to you to make you immunocompromised. So that would be things like lung transplant or immunosuppressing drugs, so some of the common drugs that we use for treatment of ILD. And so with that, which vaccines are covered or free in BC, just as an overview. So the ones that are covered, COVID is covered for everyone, influenza is covered, and certain pneumonia vaccines. Pneumonia vaccines get complicated, and we'll touch on that. I'll get into more detail about that. The ones that are not covered or free doesn't mean we don't recommend them. It just means that the government hasn't decided that we need to launch a full-scale vaccination program, is the RSV vaccine and certain pneumonia vaccines. These are two of the newer pneumonia vaccines. So first, COVID. So I'm not going to belabor COVID because I know that everybody's sort of familiar with this. Hopefully everybody in the room has had a few COVID vaccines by now. Sometimes I'm running into people now who have had 8 COVID vaccines. But this is sort of hot off the press this week. Actually, I should say last week is when Health Canada finally gave us the rubber stamp approval for both the Pfizer and the Moderna vaccines, the new ones for the new strains. And in Calgary, at least in Alberta, they're supposed to be approved and available to purchase to get in mid-October. So I would anticipate that we're going to see these coming up in the next couple weeks. But I haven't heard anything about BC yet, but I would imagine they'll probably be in the next couple weeks. So these ones cover 2 new strains. The letters aren't super important, but for those who do find them important, the JN1 and the KP2 strains, and these are actually the ones that are circulating in our environment right now. So if you have heard of somebody recently getting COVID, if you've had COVID recently, these would be the strains that you would have come into contact with. And so that's why for COVID, it's important to stay up to date on these vaccines because the strains consistently change. There is a new vaccine called Novavax you might have heard of. So this is different than those mRNA code vaccines that I told you about on that earlier slide. These ones use a protein. Again, it's more of a traditional vaccine that just uses the full protein from the antigen. This one doesn't have the KP2 strain. It only covers the JN1 strain. But that's still the parent strain. So we still think that this is kind of the main strain to get. So it's still a good option if you want something different or if you can't take an mRNA vaccine for some reason. Perhaps you've had a reaction in the past that precludes you from taking that vaccine. These ones are shipped from India, so they're not made within North America, and they've left it up to the provinces to decide who actually gets this vaccine. So we're not sure whether or not this is going to be available in BC yet, but if it is, this is a very reasonable option. So who's eligible? Everybody in this room. We're all eligible, unless there's like a infant hiding somewhere among us. Our recommendations haven't caught up to the new vaccine yet, so I don't know exactly what they'll be recommending for schedule, but I will tell you about what we were recommending for the previous version, the Omicron version. So if you didn't previously have it, you should have at least 1 dose, okay? You were eligible, and that doesn't mean unvaccinated. If you're unvaccinated, you actually have to go through a whole series of doses again. But if you didn't have the most recent vaccine, so say you only got the first 2 or the first 3 COVID vaccines, this new one that came out in fall 2023, it was recommended you should have at least 1 dose of that one. You would be eligible for a second dose if your age is greater than 65 or you're immunocompromised. So not everybody with lung disease doesn't need to get 2 of those same vaccines, and I anticipate it'll be the same with this new JN1 KP2 vaccine that's coming out, that if you're immunocompromised or older than 65, you could get like a booster dose 6 months later. You don't need to wait for the next year. The vaccine should be separated by 3 to 6 months. So the question is, which one's better? Should I get it in 3? Should I get it in 6? It's a bit of a trade-off. The immune response is better if you wait 6 months. So the longer you wait, the better the immune response. The people we treat at the 3-month mark are those who are more immunocompromised, those where we just don't want to wait as long. So it's a trade-off knowing that you're not going to get as good of a response, but we're going to at least protect you sooner. Again, that's why it's important to talk to your doctor about the trade-offs between waiting or not. To book an appointment or register for vaccine notices, you can go to gov.bc.ca/getvaccinated, or you can phone the number here on my slide, and you can actually register and get vaccine notices sent to you by email or by phone so that you know when the new ones are coming out and when you're eligible for those vaccines. So the frequent questions I get asked, should I wait for the new shot? And sometimes that's a really hard question to answer. I'm very lucky that today is September 27th, so we're probably only going to need to wait a couple weeks before the new vaccine. So at this point, it definitely, yes, just wait a couple weeks for the new vaccine, even if you didn't have the other previous one. They're actually trying to get rid of all of the old vaccine supply, but you can wait until this next one. I don't have any preference, and I think most doctors have no preference between Moderna, Pfizer, or Novavax. They all work very well. I recently had COVID-19. Do I need the vaccine? Yes. So if you've never been vaccinated, we again recommend getting vaccinated earlier to give yourself good protection, so about 4 to 8 weeks after the infection resolves. If you've been vaccinated, we say wait a little longer. Again, give yourself that boost in immunity that you get when you repeat your exposure to that virus or components of that virus, and that would be the optimal time frame. We're going to switch gears a little bit and talk about flu. So you can actually get your COVID and your flu vaccines at the same time. And this has sort of changed. The messaging has changed here. It used to be that we would like to space out vaccines. The thought would be that you don't want to confuse your immune system. They know now, we've done a lot of studies on this, and we've seen that influenza and COVID together actually doesn't really affect your immune response too much. And then the good thing is that you don't need to make 2 trips. You just go for one, get a shot in each arm, and then you're done. With influenza, similar to what we're seeing with COVID now, we're entering these sort of vaccine cycles. The current vaccine only covers for the current season. So even if you've had the flu shot every year for the past 10 years and you missed this year, you're still not really adequately covered. And the flu vaccine is actually a tricky one. And we get this feedback all the time from people, well, I got the vaccine, I still got the flu. And that happens a lot. It doesn't protect you necessarily from getting it, but it should protect you from more severe illness. It's mostly because of how the vaccines are developed. So they develop them based on guesswork. So the World Health Organization and all those people who are very smart and working at WHO, they kind of determine what variants are most likely in the Northern Hemisphere, and then they create a vaccine. They just modify the vaccine slightly from the previous year to match the current variants. But we still think everybody with lung disease, pretty much everybody should get vaccinated, but especially those with lung disease, definitely those who are immunocompromised, and your family members and close contacts. So make sure that all the people around you are also getting vaccinated. Very important. Which vaccine should you get? Because there's usually kind of 2 groups of vaccines that are offered for influenza. And for those who are under 65, the one that's most commonly offered are the sort of standard dose, or you'll hear the regular dose influenza vaccine. And these are the 2 ones that are available. It may vary based on your local pharmacy or what part of the province you're in, but these are considered to be essentially equivalent, the Fluzone and the Fluaval. If you're 65 or older, it's recommended that you take the Fluzone high-dose quadrivalent vaccine, and so the idea is that you actually mount a better response. They looked at folks who are under 65 versus over 65 in studies, and they found that those who were over 65 didn't mount as good of a response to the lower dose, and that they actually got way better coverage. This was a study done about 10 years ago. They found that they were 60% better covered with the high-dose vaccine. There's also another one here, Fluzone and Fluad. The Fluad vaccine actually is just the standard dose, but they've added an extra ingredient that boosts your immune response. Now I'm going to switch gears a little bit. It's going to get somewhat confusing when it comes to pneumococcal pneumonia, and I think this even confuses a lot of physicians when they're trying to develop what vaccine should I recommend to patients. And part of this is, the reason for this is that the guidelines have changed recently. So I'm going to talk a bit about how pneumococcal pneumonia vaccines work, because when we talk about pneumococcal pneumonia, we're actually talking about bacterial pneumonia. And so most of our vaccines are based on this technology to target viruses. But with bacteria, unlike viruses, which are recognized by proteins, bacteria are usually recognized by sugars or polysaccharides. okay? And so what we actually have to do is we have to find a way to engineer these sugars in a way that our body can recognize them. So this is supposed to be a bacterial cell, okay? And so bacterial cell is pretty simple, more simple than our human cells for what it's worth, and they can wreak a lot of havoc, but they also, their calling card is on the cell wall, so we'll talk about that. And when we talk about pneumococcal pneumonia, we're referring to streptococcus or strep pneumo. So this is similar in a way, sort of a cousin of what gives you strep throat. The most common, and this is the most common cause of bacterial pneumonia. So these vaccines take up components of the cell wall, again, some of those sugars from the cell wall that we're able to isolate. And so what we do is we either take the sugar itself and kind of like add something onto it, or we conjugate it to a protein. And so these older vaccines here, we have Pneumovax, PPSV23 is how it'll be written on your official record, or we have Prevnar, PCV13, which a lot of children get. Okay, so Pneumovax is the one that you usually get in adulthood, PCV is the one that kids have gotten for a very, very long time. These are the new versions. So this one, we have this PCV20, and this one is called Prevnar 20, or PCV15, which is Vaxneuvance. So what do all these numbers and letters mean? It has to do with the technology and what they cover. So the number refers to the number of different strains covered. And PCV means that it's conjugated to a protein, which is why you get that better protection. Technically, the response is better with all PCV vaccines because they're conjugated to a protein, and our body better understands those than just giving us sort of the sugar with some other ingredients that help with the immune response. So we know that this new vaccine, for example, covers 20 different serotypes or strains compared to the older vaccine, PPSV, which is just the sugar, and it covers 23. So you can kind of already start to imagine there's a bit of a trade-off here. PCV20, better immune protection, conjugated. PPSV, just the sugar, but it covers a little bit more in terms of the strain. What we've learned now is that it's actually, and I'm just going to say, this one, PPSV23, is still good, but maybe less long-lasting than the PCV20, okay? And that's why these are coming out as new vaccines in the newer recommendations. The PCV15, I should say, the one on the bottom line compared to PCV13, definitely better because it uses that same technology, so immune response is the same, but you're getting the benefit of 2 other strains. So what's offered by the province? The old vaccines are what's offered and what's covered. That doesn't mean they're bad. It doesn't mean that the people making these decisions don't know what they're doing or they're trying to cut corners. These are still really good vaccines, and they've been used for a really long time, and they dramatically reduce the rates of pneumococcal pneumonia. So what we've said with these are that if you're over 65, no matter whether you have illness or not, you're healthy, you should get it once. If you have chronic lung disease, all ages, you should get it once. If you're immunosuppressed, all ages should have a repeat 5 years after the first dose, okay? PCV13, so most folks don't need this in adulthood, but if you're immunosuppressed, you should actually get PCV before you get the PPSV23 or the Pneumovax vaccine. So if you're somebody who's taking an immunosuppressant for your lung disease, you should actually get the PCV first, and then the Pneumovax you should get 8 weeks later. And then again, since you're immunosuppressed, we're going to repeat that one in 5 years. If you've already been given the PPSV23, say somebody wasn't really sure what to do, you can still, all is not lost, you can still get the PCV vaccine. You should just get it 1 year later. Now this is different than what's recommended by our Canadian body. Our Canadian body, like the Canadian governing body that has approved the new Prevnar, has said that everybody over 65 should get a dose of this vaccine, even if you got previous vaccines. You should wait about 5 years from the previous Pneumovax or PCV13, so you can still get this, Even if, for any of you who've had your pneumonia shot within the past, or over 5 years ago, you could actually purchase this one, so PCV20, Prevnar 20. If you're 50 to 64 and you have chronic lung disease, you can get PCV20, and adults over 18 with an immunocompromising condition. These are the people that can go and get the vaccine, can purchase the vaccine. Again, wouldn't be covered by our province. If you have private coverage, this might be paid for, and you could definitely make an argument for that. So get your doctor to write you a prescription, and then you can check in with your coverage to see if this is covered, because we do have good Canadian recommendations that do say that this is the new recommended approach. What I recommend is that if PCV20, if cost isn't a barrier, you have private insurance, or you'll just pay for it, it's about $250, I believe, then go ahead and buy the PCV20. It'll cover you for longer, probably the rest of your life. Otherwise, the Pneumovax is still a very good option, and I still recommend getting that. Now we're going to switch gears a little bit to RSV. And this tends to generate a lot of questions. RSV is something we haven't talked about a lot in the community, because it wasn't really top of our mind until after COVID. So this is a very common contagious virus that tends to cause mild symptoms. In severe cases, it can actually send you into the hospital with pneumonia, but even in a milder case, if you have lung disease or if you're immunosuppressed, it can be problematic. We know that it's problematic specifically in people who are over the age of 75. And this is so common that they actually say that the majority of kids under age 2 already have some evidence that they've come into contact with RSV. So they went and they took the blood of a bunch of little kids, and they found that over half of them already had exposure to this. So that's how common it is. It's the leading cause for hospitalization in kids. Usually the season is in late fall to early spring. And so the question is, why are we talking about it now? Why has everybody heard about it now? What ended up happening after the pandemic is that we were all kind of immune naive to RSV again. We were isolated, we were wearing masks, and nobody was getting RSV. Kids weren't coming into hospitals sick with RSV anymore because they weren't in daycares. They weren't, seeing other people. They weren't seeing their grandparents. And then we saw this influx of RSV, and there had actually been, sort of in the background, a lot of talk about vaccines for RSV. And so there had been like a sort of 10 years of development going on in the background before COVID for an RSV vaccine. So then there was this big push after COVID to actually get RSV vaccines. And now we're finding out that there's a lot more adults who actually have RSV or who have gotten more severe RSV. It's probably still not any more severe than it was pre-pandemic now that we've kind of reached this sort of equilibrium in the community. But it definitely still exists. So there's 2 RSV vaccines, Arexvy and Abrysvo. And these are recommended essentially for everybody over 75, anybody over 60 and who's living in chronic care, and those who are 60 to 74, depending on discussion with your healthcare provider. So if you have severe respiratory disease, or what I say is frequent exposure to young kids, particularly those in daycare. And so this should really be all of our respiratory patients who are over the age of 60 should consider getting this vaccine. I'm going to pause here again just to add to something, because I think Dr. Marinescu finished off nicely on a talk about exacerbations. And the interesting thing about exacerbations are that in the vast majority of exacerbations, we actually don't figure out what the cause is. So we call them idiopathic exacerbations. Again, that word idiopathic, because we don't know what caused them. But we know that there's a seasonality to exacerbations. So, it makes you think, is it possible that, RSV being as common as it is actually does play a role in that seasonality and in those exacerbations that we see in the winter months? So I see these vaccines as being an important step toward preventing exacerbations as well by that logic. These are the common vaccine side effects. I know that there's been a lot of talk about some of the more severe vaccine side effects that people experience. Again, those are very, very, very rare, and all viruses whether they lead to, all viruses. This one thing we talked about during COVID. There were rates of severe myocarditis with the vaccine. Those rates of severe illness were still far, far lower than what we were seeing with people who were actually infected. So it's still in your best interest to get vaccinated. The common ones, fatigue, sore arm, you may get a fever, you may feel nauseous. These things will pass usually 24 to 48 hours later. Oh, and I'm going to go to questions here and just pause.
I was just wondering, I don't know if anybody else has this problem, but we don't know when you go, what is your COVID, what was that COVID vaccine? Was that your first, your second, your fourth, your eighth, and all these different vaccines, are they taken down and put on a record that we know we've had them? Or?
Yeah, that's a good question. So you won't see it, but we can all see it. So we go on to Care Connect, which is sort of our BC way of viewing all of your health records. Your family doctors may not all have access to Care Connect. We do, as respirologists who work in the hospital. The hospitals have a way to get access to that. So we can usually go in and see, based on when you got the vaccine, what vaccines there. And I actually believe that the actual which exact vaccine you got is actually listed on that list. Not all vaccines may be listed there. Or if folks went and got vaccines outside of the province, they wouldn't be listed there. But we can actually go back and see if somebody had their pneumonia vaccine, if somebody had their COVID vaccine, for example.
So when you go into Shoppers Drug Mart to get your COVID vaccine, your most up-to-date one, do they say, oh no, you already had it, you had it 2 months ago?
So that's the tricky part that you run into, especially with the newer vaccines. So if you say, for example, just got vaccinated a month ago or 2 months ago, they won't want you to get the updated COVID vaccine because it technically hasn't been long enough since your last shot. So you're all, and I don't want to give the impression that you're not well protected if you don't have like the latest and greatest and the newest vaccine. You're still probably very well protected even if you've had the other shots. So I would wait another few months in that case.
Okay, but is it, they know that you've had this previous vaccine when you go in to get the next one, or?
Yeah, they should. They would know if you've had the previous one. They'd have a way of finding that. I can't speak to pharmacies only because they should be able to access it, but I've never worked as a pharmacist, so I don't see what they see. That's if you've been prescribed it, that's true, you can see it on Pharmanet.
I'll add a note too. The province has a health gateway. So you could sign up for yourself to get access to what you've filled at the pharmacy. It has a whole list of all your prescriptions, including vaccinations. So through the BC government website, Health Gateway.
Nice.
Yeah, through your BC service card. There's an app, you go in and it lists everything you've had. Whatever go through the BC service card account. It's a bit of a.
Once you get on, it takes a bit to navigate it, but it gives all the information. It'll tell you all various shots you've had, and it's your health record that's on the system. Well, it's more than that, but yeah, it's a bit of a process.
It'll guide you through.
Yeah, it'll guide you right through how to do it.
Well, that's a great learn for me. We didn't have that in Ontario, I can tell you that, so that's nice.
I have a question, Dr. Leigh.
Yeah, and then there's one in the back too, so I can.
Let's say you get COVID. Paxlovid problem. The Paxlovid problem, it creates real challenges again for the rural community because the family doctors don't often know how to access it. The pharmacist is telling me that, and I'm really sick, I have to pay $1,200 for this medication. So the communication with the family docs is dismal. And so as a result, patients have to advocate for themselves at a time when they're their most sick. And so, and I don't know what the government's doing about that, but it was me that had to finally find out how to access the Paxlovid, get the Plan Z filled out. And I can do that, but not everybody can.
Yeah, and one of my areas of interest is actually quality improvement in the healthcare system. So I see a lot of room for improvement in processes that we have. And I always say to patients, and I'll say to you all today, is that in our system, the squeaky wheel gets the grease. You have to do what you can to advocate for yourself. You're not just being annoying to go to your doctor and bug them about things. I encourage it. I encourage, if you need something and you're sick, call both your family doctor and your respirologist, basically anybody who will listen, because in an ideal world, we will repair these problems, and I hope that we can repair a lot of these problems, but you know, you and your family members are really still your strongest advocates through this system.
Okay, how are we for time, Dr.? Okay? Okay, Darcy, you have
Yeah, I just have a simple question here. Does the COVID vaccination always have to be in the left arm?
No,
Has
you
anybody
can,
experienced that, where the next day you can't even feel your arm, it's so painful?
yeah, I've
You can request
experienced
the
that
other arm?
myself. You can request the other arm, and they
Okay.
can actually, I mean, for people who are double amputees, they can get it in different muscles as well, so. Yeah,
Oh, interesting.
yeah.
I don't know if anybody else has had arm pain, but it's can be pretty sore.
If you've experienced that before, you can ask for the thigh. There's a,
You can?
Oh,
You can
yeah.
ask for the thigh?
Oh, you can, yes, for
Okay.
sure you can.
Good to know.
Yeah.
Thank you.
so I'll just interject here. It's been very popular, the topic that you've got. With several people asking if you can share the slides. And what's going through my mind, perhaps working with...
Can't hear you back here.
Speak into the microphone.
You want to speak into this
it.
one?
Talk to it.
Sorry about that. Going around the room, I've had several people ask if they could have the slides, and I think maybe the answer here is a working committee of Dr. Biagton and myself and you, and maybe just working out a pamphlet or something that we can email if you request it, that type of thing. Or when you come into the doctor's office, we'll have it kind of sorted out in a very basic plan, rather than worrying about slides and all the rest of it. It won't be done overnight.
Yeah, and it would also need to be in a format that gets updated frequently, because, you know, these vaccines and the recommendations are changing all the time. For some things like Pneumovax, that hadn't changed in years, decades, and then now we have these changes all of a sudden, so it can be very hard to kind of keep up with, but that does, you know, raise the importance of having something. I should mention that the Government of BC website keeps really good up-to-date records about, you know, what vaccines are available based on your age. It's not always the best for like nuanced things like, you know, if you're on immunosuppression or you have a chronic lung disease. So I think having something focused for chronic lung disease would be awesome.
Any more questions? Yeah?
Just have one question. It's thanks, man. Prevnar 13. What kind of an effect does that have with mycophenolate that I take?
So it's not like it's going to interact with it poorly in any way or cause some kind of side effect more than, you know, your typical vaccine side effect. You may not mount with any amount of immunosuppression you're on, whether it's mycophenolate, particularly with things like rituximab or what we call B-cell depleting therapies. The treatments will kind of slow down your immune response to the vaccine the same way that that those treatments also slow down the immune response to other things like lung transplant, like you know, attacking your new lungs, or like attacking your own body in the case of autoimmune disease. So it's not going to interact poorly in a way, but you may not mount as good of a response to it.
We're going to have to interject here because we've got somebody on Zoom. Dr. Nayar is coming on. Thank you so much. You have no idea how much we appreciate it.